Thank you, Germano. Could you hear me?
Yes, I can hear you, see you. You're all good to go.
Thank you very much, Germano. Thank you, Sheriff. Thanks again to the organizer, Professor Nassef, Professor 𝗙𝗏𝗏𝗀𝗏, to give me the privilege to be here in this session. The first treatment was reported in literature about the treatment of thoracoabdominal aortic aneurysm in 2001 by Schutter. After that, we can see different experience reported in the literature regarding the treatment of degenerative thoracoabdominal aortic aneurysms. In 2010, we had this paper published by Roy Greenberg, and they reported a good result in comparison between endo and open. After that, they underlined that the advantages of thoracoabdominal aortic endovascular repair were related to the no aortic cross-clamping, no thoracofrenular aportomy, no single lung ventilation of visceral ischemia. After this experience, other experiences were reported in Europe and United States from Stefano Lon, Eric Verhoeven, and 𝗙𝗏𝗏𝗀𝗏𝗏𝗏, not only regarding the perioperative treatment and perioperative results, but even regarding the survival and freedom from reintervention, the follow-up of our patients, with very good results regarding the treatment of these patients. If you look to the Italian experience, we recently published an Italian multi-center registry regarding the treatment of the aortic disease with advanced technology. In this group, we have 351 thoracoabdominal aortic aneurysms. The technical success was 91% with 11% of spinal cord ischemia and 5% of permanent paraplegia, 8% of mortality. If you look to the follow-up, you can see the freedom from target visceral vessel occlusion in thoracoabdominal was 88%. And if you look to the freedom from reintervention regarding thoracoabdominal, again, after 5 years, 68%. Then I want to stress some aspects of this treatment. First, endograft. We have two different options, custom-made off-the-shelf. Off-the-shelf, we have different brand, different possibilities inside term a T-branch. But I think that it's important to stress when it is possible to treat a patient with custom-made or off-the-shelf. Generally, we prefer off-the-shelf in patients with continued rupture, symptoms or diameter more than 7 or 8, according with the literature. Regarding iliac access, generally we have this device with more than 20 French. Then it's very important to define correctly the navigation of the device inside of iliac vessels. And we know that if we have an hostile anatomy in iliac access, you can see here, we can have an increase of mortality of these patients in the perioperative period and even in the follow-up of this patient. Then we think that it's very important to evaluate carefully the iliac characteristics to adjunct some procedure. Frequently we need a conduit because this is very important regarding mortality in our treatment. Another important point is visceral vessel revascularization. Generally, in patients with fenestration, the first choice is always the balloon expandable covered stent, according with the literature. But if you look to the branches, we can use a balloon expandable cover stent in the treatment of celiac trunk and superior mesenteric artery, but we have to define better the anatomy of renal artery, because we reported in this paper published in 2018 that the type B and type D renal artery anatomy is are a risk factor for the occlusion of the stent graft in the follow-up of our patient. Then in this type of lesion, generally we prefer the hybrid approach, distally with self-expandable stent graft and proximally with balloon expandable stent graft. And we published 2 years ago our results, and we can see that the group of patients with balloon expandable and self-expandable have an increase of the patency of renal arteries, and they have an increase of freedom for intervention, and even regarding instability of the branch. Then in patients with type B and D renal artery anatomy, our approach is proximally balloon expandable and distally self-expandable cover stent, like this patient with this anatomy regarding the renal artery. Another very important point is spinal cord ischemia. Again, if you look to the Italian multicenter registry, you can see this paper that comes from our group, the group of Germano Mezzano and other 3 groups. And they reported in this paper that there is an increase of spinal cord ischemia in Crawford extent 1 to 3, in ruptured thoracoabdominal in patients with bleeding and renal insufficiency. How it is possible to decrease the percentage of these complications? According again with another paper published by the Italian group, the first name comes from the group of Germano. Again, they reported that both historical planned procedural staging were associated with reduced permanent spinal cord ischemia. Then again, our papers reported that we need staged treatment in patients with thoracoabdominal aortic aneurysm. The other point is the new approach to post-dissection thoracoabdominal aortic aneurysm. In this type of lesion, we recently reviewed again the experience that comes from a national multicenter Italian study, and we collected even the review of the literature. You can see the technical success in this post-dissection thoracoabdominal aortic aneurysm treatment comes from between 89 and 100%, with spinal cord ischemia between 0 and 16%, and if you look at dialysis, 0 and 5%. These are results in the perioperative period, and if you look to the follow-up result, the mean follow-up between 12 and 26 months, you can see high percentage of reintervention and the endoleak in these patients. The last point is the survival after 2 years between 81 and 93%, with a good patency regarding target visceral vessels, with a false thrombosis between 65 and 94%, and stack shrinkage between 80 and 95%. We have other options, other opportunity to treat with endovascular therapy the thoracoabdominal aortic disease. We can treat even patients with previous open or endovascular abdominal aortic repair, and we can treat even patients with visceral aortic patch aneurysm, according to this paper published in Transatlantic Aortic Research Consortium investigator by the group of 𝗙𝗏𝗏𝗀. Then, ladies and gentlemen, in conclusion, the total endovascular treatment of thoracoabdominal aortic aneurysm is evolving. The short and midterm results seem encouraging endovascular treatment thoracoabdominal aortic aneurysm, the first choice in some thoracoabdominal aortic aneurysm. Thank you very much for your kind attention.